So are we live? Or should
Yes, are we live? Can we start?
I give you count.
I don't have a screen here in the category settings. I'm just looking at the time. Yes, I think that's right.
today, which we are going to do from Mumbai, and it is my pleasure to introduce the surgeon of the day today. Uh, it is none other than Dr. Anagha Heroor, and Anagha is very well known to all of us. She is medical director of Anagha Hospital, Dombivli at Mumbai, and she is also the chairman or chairperson of the Gopal Krishna Charitable Trust and member of the ARC West Zone, AIOS. She's honorary joint secretary for Maharashtra Ophthalmological Society and executive member of IRSI, ex-co-editor of AIOS newsletter, member of the FBS Women's Empowerment and Networking Committee. She did her MBBS in 1992 from Lokmanya Tilak Municipal Medical College, Sion, Mumbai. Needless to say, she was the topper with numerous prizes, gold and silver medals. She's done her MS in 1997, again from Sion Hospital, Mumbai, and she was again topper in those exams as well. She has to her credit whole set of awards and presentations, international presentation and video presentation at ISCAS 2018-2019, performed live surgery at various conferences and numerous academic presentations in various regional, state and national and international platforms. She's won the Best Surgical Video Award at Rajasthan Ophthalmological Conference in November 2018 and Best Surgical Skills Award by Women's Ophthalmological Society Conference, December 2018 in Hyderabad. Best Team Scientific Presentation in Interstate Competition, again on the platform of WAS Bengaluru in September 19, and winner of Best Surgical Video Challenging Cases, September 2019 in Roscon, Jaipur. To her credit, she has the awards such as the Bhishgavaria Award for the Best Doctor of the Year 2012, the IRSI Gold Medal Award at the hands of Vice President of India, Shri Venkaiah Naidu. She's been awarded the Dombivli Bhushan Puraskar Business Leader Award and the Gold Medal at the iBeach Film Festival, Goa, as well as the RJK Singh Community Ophthalmology Award in October 2019. And she's going to be showcasing her surgeries, and I have with me Professor Rajesh Sinha, who's the treasurer of All India Ophthalmological Society and who's the consultant in cornea, cataract and refractive surgery services at RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences, who would be co-moderating the session with me. So welcome everyone again to this Surginar, and over to Dr. Anagha for her demonstration of the live surgical cases.
Thank you so much, ma'am, for the kind introduction. A very good evening to everyone from Mumbai. At the outset, I'd like to thank you, Dr. Nandita, and Dr. Rajesh, for giving this opportunity. Privilege and honor, and I'm thankful. So, we'll be showing the few cases today, and I'll be starting with the front on the Catalyst platform. This is the right eye of the patient. Papa, no need to. सरळ बघायचं ना, दोन्ही डोळे उघडा नका, सरळ बघायचं सरळ. So the catalyst platform is basically for the frontal laser right now. दुसरा डोळा पण उघडा. हा, इथे बघायचं बघ. बोटाकडे बघा या डोळ्याने. So it has a suction cup ring which is around 13.5 millimeters and it has a liquid optic interface. So we have injected VSS into the cup. आता दोन्ही डोळे उघडे ठेवा. समोर एक रेड लाईट दिसेल, दुसरा डोळा पण उघडा, सरळ बघत राहायचं, हलवू नका अजिबात. व्हेरी गुड, तसंच बघत राहा. So we are docking the patient, taking him under the laser platform. There are two steps to it. The vacuum, the capture, and now we have locked the machine. काका सरळ बघत राहायचं, हलवू नका अजिबात. So there's an integral guidance system. So there's a 3D spectral domain OCT which is attached to the machine. And it actually delimits the anterior surface of the cornea, posterior surface of the cornea, the anterior lens capsule, delimits the pupil so that it gives a perfect and precise and accurate capsulotomy nuclear fragmentation. So we will be using these two modules of the Catalyst platform. So if you can see the screen, I hope you're getting the feed. So you can see the capsulotomy is just 1.5 seconds. Kaka bagat raha. So the patient just needs to keep looking straight. There's a red light, and here the nuclear fragmentation is being carried out. It's a quadrant type of nuclear fragmentation that we have customized for the patient. So as you can see, it's already complete. So it's a very quick procedure. झालं काका? दोन्ही डोळे उघडे ठेवा.
What is the size of your capsule?
It's 4.8 millimeters.
Okay.
So we usually set it at 4.8 millimeters so that for any kind of intraocular lens, it will easily get, or each lens can be centered perfectly well. So I'm just washing up by the time the patient is being shifted to the main OR for the phacoemulsification part. The best part about the catalyst system that I found is the liquid optic interface. So because there is no applanating surface, there are no folds on the posterior surface of the cornea. So in certain other systems where there is an applanating surface, those folds can actually cause aberrations in the laser delivery. So, and the IOP rise is also not very high. So initially, like glaucoma used to be considered as a contraindication. So nowadays we do catalyst and frontal laser even in those patients. So it actually doesn't really have so much of an issue, as well as the amount of subconjunctival hemorrhage that we are seeing is also much less. So what has been your experience, Namrata ma'am, on this?
No, for us, actually, we don't have a catalyst, so we do on another platform. And that platform is also quite good, but I think catalyst is slightly faster than the that we have. I just wanted to know from you that if you compare Lensex vis-a-vis catalyst,
yes,
then do you make incisions on your catalyst machine, or you'd rather make incisions with the keratomes?
Keratome, yes. I usually make incisions with the keratome itself because I feel catalyst, the plus point is more for the capsulotomy and the nuclear fragmentation. So I prefer to do the incisions manually only. But it works really well for the capsulotomy. As you saw, it was just 1.5 seconds. So it's a very quick one. Another difference between this and the Lensex that we have found is in the catalyst, the biggest advantage is patient care. With the catalyst,
one more advantage perhaps
is the fragmentation of the nucleus is throughout the pupillary area. Whatever is part of the nucleus is visible, the lens is visible. Whereas with the Lensex, it's only limited to the capsulotomy part.
Yeah.
So that is a major advantage. Height kami kar, that's it.
So we have this case one already slide which is there, which can be seen. Can we
Yes.
project the slide, telling about the patient details, please?
So this is it visible?
Yeah, it is visible.
Yes, so it's a 75-year-old male,
Yeah.
diabetic, hypertensive with liver cirrhosis. Otherwise, pseudophakic operated just last week actually. So this eye to be operated is the right eye. We are planning for a Technics toric lens. As you can see the keratometric readings, the right eye, it is 42.35 at 88 degrees and 43.69 at 178. So a plus 1.34 at 178. And the IL power is 18.5. So I'll be sitting temporally. We are also using the Varian platform. देखो ये बाजू लेना है, देखो ये
Okay, so now we can see the chart which was of the Technics toric shown at
yeah,
what?
so this was on the Barrett toric calculator. As you can see, the incision is around 160. Lens axis is at 2 degrees. It is the ZCT 225. Next please. So we are just starting the case. It's under topical. हनवटी खाली ठेवायला.
So can we have the microscope view?
Yes, yes. We are just starting. They just
Okay.
sticker
So you are doing it under topical anesthesia.
topical. Yes, yes.
So again, like I think betadine painting is very important, and that seems to be the only factor, or in fact, one of the most important factors that helps in prevention of any kind of infection.
Absolutely. We also put in, correct. We also put in the conjunctival cul-de-sac before taking up the patient here in the OT.
And then apart from that, I think that area has been dried also.
Yeah, many times otherwise it doesn't stick really well, the drape. So that is why we prefer to dry it. Otherwise it becomes a little loose. We also have usually we follow the format of saying time out of the patient. So like for example, if you have 4-5 cases, so the moment just before we start the case, we have one sister who calls out the name of the patient with which eye is being operated, what kind of surgery and what lens and the lens number, so that everybody in the OR knows, including the surgeon, the assistant, as well as the anesthetist and the patient also. So according to the routine rules, so that everybody is aware about what case is going on. Okay. So just starting the case. काका दोन्ही पण उघडे ठेवा. हा. Right.
We are using a signature pro machine.
Yes, yes, ma'am. So using the signature pro machine. So this is the timeout which is being told. So I have the chart of the patient on my left so that I can see exactly the site of the incision as well. Kaka doni dole ugde thela. Usually prefer to keep the light of the microscope a little low initially so that the patient immediately as he opens the eye, the light is not too much so that he doesn't. Kaka doni dole ugda. Aramat ugda please. Ha. Normal ugda. Saline.
Okay, so we've seen the chart also on your left side.
Yeah. काका सरळ बघायचं लाईट मध्ये बघ हा लाईट मध्ये बघा
We have the microscope view, yeah.
Microscope view is it?
Yeah, we can see very well now.
काका सरळ बघत राहायचं. We have started the Varion also. Can you see the overlay of the Varion?
Yeah, no overlay we can't see. I think for that you'll have to show us the screen. Yes, now we can see.
Okay,
Now we can see.
Yes, so the axis is 160 degrees for the incision. I'm just making the entry there. Side. Kaka, सरळ बघत राहा.
So Berion is an image-guided system which actually tells you where your
काका
main
लाईट मध्ये बघत
should
राहा.
be, where your main incision should be, your side port should be, and what should be the
Eyelashes सर.
and what should be the axis of the lens when you actually finally place it. So it is very useful. If you have a digital system, you don't have to mark it manually. Can we see the microscope view, please? Yeah.
Is it clear?
Yeah, very clear.
So I'm just injecting. काका लाईट मध्ये बघत राहायचंय काका. हा हलवू नका. Injecting a little intracameral lignocaine.
Okay. Do you use phenocaine or lignocaine routinely?
Only for those patients where the pupil is not dilated, then I use phenocaine. Otherwise, for topical patients, only lignocaine. So now this is the place where I need to enter. काका सरळ बघत राहा, हलवू नका. Is it visible clearly?
Yeah, very nicely visible. The
2
side
millimeters into the limbus. I usually switch off the third part of the microscope and then put in only the coaxial. As you can see, there are two lights. Kaka, दोन light दिसतील आता. Okay, तिथेच बघत राहा. It usually reduce the pressure of the speculum also at this point. As you can see, the capsulotomy has already been done by the femto. So depressing the posterior lip a little bit, egress a little bit of the visco, doing a very gentle hydrodissection. Already there are those air bubbles inside. Yeah. Tapping the nucleus in the center. Kaka light मध्ये बघत राहा. So now we no longer need the Varion right now. So I'm just switching it off. वरचा light off केला तरी चालेल. Just checking for the mobility of the nucleus now. Yeah, so it's freely mobile. You can see the capsulotomy flap also. So that will come out when we are actually doing the echo. काका लाईट मध्ये बघत राहा. थोडं पाणी येईल, प्रेशर येईल. ओके. Side full saline, okay. Yeah, so now the sister also tells out what is there on the screen. So it's on the phaco mode. सरळ बघत राहायचं काका. Just check whether the flow is good or not outside the eye, then going in. थोडं प्रेशर येईल काका. Just removing the superficial cortex and epinucleus. So you can see there are a lot of air bubbles. Kaka, halvu naka, halvu naka.
I think with the femto delineation, you do expect that the air bubbles are going to be there because
Yeah, so that's why I just tilted the saline. Tilted the probe a little bit, handpiece, and removed the air bubble.
and again, in these cases, when you're doing femto delineation, you should not be, it's already there, you should not be very aggressive about
Hydro, saline. Yeah.
I think already
You can split it so easily because of the femto. You can see the already two hemispheres. Quadrant, vacuum, 400.
I think you made 4 cuts initially, so it's really important to just open those cuts.
Yeah. Saline. Saline. It's not a very hard cataract, it's a nucleus grade 2.
you
So I
can see
think
this
for
part is on the, yeah.
grade 2, you would probably need only 4 clips and you won't.
Yeah, that is why we didn't even do this softening.
Yeah.
We just did 4 quadrants, but if it was a very higher grade, denser nucleus, then we would have gone ahead with maybe a 6 quadrants along with softening. काका हलू नका, सरळ बघा.
I think one should see the dynamics of the anterior chamber are really fantastic, and the chamber is absolutely rock solid. There is no surge at all, even during the last piece, which is which is coming out so easily.
So you can see the followability is really good, as well as the stability of the chamber. Kaka सरळ बघत राहा. हाँ, देखो. सरळ बघत राहा. Okay? The pupil is slightly on the smaller side, so I'm just putting it a little bit of phenokin. So you can see it's dilating enough or adequately enough for us to see the capsulotomy edge. Putting in a little bit of viscoelastic. Now we'll be doing the irrigation aspiration. Now in femto, the IA part is slightly different from the manual part because the fibers are vertically cut. So we need to just tease off the fibers from underneath the anterior capsular edge. Saline galat.
Cortex side full saline, okay.
Yeah.
So you're using the irrigation aspiration. Which company that would be?
Bimanual one. The bimanual irrigation and aspiration.
Yeah.
Saline. Lens ready? Lens there, sir.
Lens ready.
So here, as you can see, I'm just going underneath the anterior capsulotomy edge and then saral baga kaka. Changing the hands now. Is it centered well?
Yeah, very well.
Saline.
You can see very nicely. Everything is, each fiber is visible there, Anagha.
Sometimes you can go into the polish mode and then just loosen up the cortex, bring it a little towards the center, and then you can aspect a line. Then as lens there. Lens there, sir.
So I think we are implanting this technistoric lens. They are showing the
saline the 2cc.
toric to 1 piece IOL.
Yes, sir.
Technis
Delay na lens.
Technis 2 on platform 2. So can you just tell us what are the changes which have come in Technis 2 platform, Anagha?
Yes, ma'am. Just a minute. Light on. So I'm just loading the lens. काका 2 मिनिटं लाईट नाही दिसणार.
तुमची लेन्स लोड होते ना.
So you put viscoelastic both in front and
in front as well as end. So because it's a hydrophobic lens, we don't want it to get stuck in between.
Yeah.
Just picking it up from the box.
That is a very nice demonstration, which normally misses during the live surgeries because it is being, already loaded. So very nicely demonstrated on how to load the lens and how to put the cartridge onto the injector. You'll use a push injector or a screw injector?
It's a push one, ma'am. It's a line, no? Okay. काका लाईट मध्ये बघा परत हा. So now the lens axis is 2 degrees. So I'll just inject the lens first and then we'll show. Okay, let's see. This deepening the chamber a little bit. Kaka light मध्ये बघा, tight मध्ये बघा. So when anything is being introduced in the anterior chamber, it's always better to see that the tip is well inside the lip and not inject it at the edge so that you don't avoid a decibel detachment. काका थोडासा प्रेशर जाणवेल हा.
So what was the size of your incision, Anagha, to begin with?
It's 2.8, ma'am. That.
Because it's a toric lens, you can see that there are 3 marks which are there on either side of the haptic junction. And I think now Anagha is going to also put on her Varion to match the axis.
Just dial it inside first.
Dr. Naga, any comparative experience on screw versus push?
I feel the screw is more controlled compared to the push, especially in those injectors which are reused. Sometimes there could be times when there could be an old viscoelastic remaining, or if it's not cleaned well, sometimes it could open up jerkily. So we just need to. So here we prefer to go underneath the lens and then wash. It's always important to wash the viscoelastic from underneath the lens also to prevent rotation of the IOL poster. Switching on the Varion.
Yeah, axis was about 160 degrees.
Yeah, so I'll just put on the Varion now. Push for the. I've kept the irrigation on. So you can see this is the axis for the lens axis, and now I'll be just rotating it.
Alternatively, when the viscoelastic is still in, then also you can rotate it and
You
then
can do that, yeah. But then once you remove the viscoelastic, again it might rotate. So I usually prefer to do it. So now it's well aligned.
perfectly align on both sides.
Aligned. So almost the viscoelastic is removed. There are 2 cc's around it. You prefer to keep the irrigation on and then do stromal hydration so that there is no sudden shallowing of the chamber.
Yeah. That sudden shallowing can also cause a
And also cause a mild rotation. Yeah, correct.
And that's a very good tip, Dr. Naga, that keep the irrigation on while hydrating the wound.
So it's still well aligned and putting a little bit of intracameral moxifloxacin. Even after removing the speculum, also I still keep the Varion on to check whether the lens is aligned.
and
It is still aligned. So just deepening the chamber, and yes, that's it. So we are done with the first case.
very nicely done, Anagha. Extremely well done.
So
and very well explained each and every
Very
step.
well explained and absolutely methodical way of doing.
I do that. हा करा ना.
We were talking about
कसा झाला चांगला झाला. Yes, ma'am.
talking about Technis 2 platform.
Yes, ma'am. Yes. How is your experience with it, ma'am?
So I feel that Technis 2 platform is quite good. Now they are coming up with a toric lens also in the similar platform.
Yeah. What is your opinion on that, ma'am?
No, it is definitely a better platform in the sense that there would be less listenings and there would be less PCO with the Technis 2 platform as compared to Technis platform which was there earlier.
Already, I think the Technics platform gives us excellent image quality. The kind of contrast sensitivity that we get with that is really unparalleled, especially because not only they have the negative aberration of minus 0.27, which can correct the positive coronal spherical aberration, but also they have the blue, yellow, the violet filter, plus the chromatic chromaline technology with their other higher lenses, also like the enhance and all. So definitely the kind of image quality that is provided if in comparison to the other monofocals is really great. So the image quality is really unparalleled, and plus with their other platforms which give intermediate vision like the iHands or the Synergy which gives good near vision also, then definitely that would be a good addition and complete kind of treatment profile for the patient.
So what is the next case?
Especially in, yeah, so the next case we are already starting. Yeah. Sakshi ikkade ya sir. It's a Synergy lens. The paper दाखवशील स्मिता इकडे ते पेपर
So it is a synergy lens, which is, and again, you're using a catalyst platform or you're doing a conventional phaco. So from what we can see is it is going to be a left eye surgery. Patient's vision is 60. Apical length is 23. Depth is 2.4. A1 and A2 are 43.44 and 43.72 respectively. And we have to implant a synergy lens of 23 diopters.
आपण लाईट मध्ये बघा. Can we have the feed from the microscope? Yeah. Eyelashes, sir.
So
the next case, Dr. Naga, is it?
This is the left eye of the patient.
Is
Yes,
it a
sir.
flax? Is it going to be a flax? Or
No. It's a conventional phaco.
can we have the microscope?
Video feed from the microscope. Yes.
Yeah, we can see now clearly.
Yeah. Is it clear? Yeah.
Yeah.
So as you can see, this is a cortical type of cataract. There is a small, not exactly a syndicate, but from the around here, I'm just pointing it out from the papillary edge. Okay. The fundus and all is normal, sir. Is it centered well?
Yeah.
It's very well centered.
So the timeout as usual, the sister is just saying out the name of the patient. Okay. So I was just saying this, like when you're putting anything into this, just for the beginners. So the tip of the instrument has to be very well inside. Otherwise, it can cause a decimal detachment not only from the main incision but also from the sideboard. So that's one. Yeah. Saline. I tend to make a slight groove first with the keratome itself and then the incision so as to get a good triplanar incision. Video feed from the microscope, please. Yeah. Saline.
There are a lot of people
Is it
watching.
visible?
Lot of people watching. Lot of the people have actually congratulated you for excellent surgery that was done previously.
Thank you so much, ma'am.
Yeah. And this looks as good as your, your Rexes before.
This is slightly on the smaller side.
Mm.
Again, egressing a little bit. I've loosened the speculum a bit. Egressing a little bit of the visco, depressing the posterior lip of the incision. Then doing gentle multi-quadrant hydro in very, very small quantities. Just enough to loosen up the endonucleus and tapping the center of the nucleus so as to not increase the pressure inside the anterior chamber too much. Injecting a combination of chondroitin sulfate and sodium hyaluronate to prevent any damage to the corneal endothelium. Being a diabetic patient, so here I'm just seeing the mobility of the nucleus. Yes, so it's nice and free.
Ready.
Yeah. So we'll be starting the phacoemulsification. Kaku light मध्ये बघा.
Saline open.
Yeah. So we're just checking how much fluid is there. So the sister usually tells how much is whether it's the saline is right or not. Okay. सरळ बघा थोडंसं प्रेशर येईल. डोकं इकडे कर त्यांचं थोडं. Just is it centered well?
Yeah, very nice.
कशावर?
Skull, high, full, saline open, medium, fat,
Just removing the superficial. Chopper the chopper. Saline. So this is again a soft cataract. Soft cataracts can sometimes be a little more difficult. डोकं इकडे कर. बस बस. Saline.
Soft cataract can be more problematic than a.
More problematic, yeah. Exactly. Saline. Yeah, so we have to immunonucleate. So this is a maneuver which I usually use for soft cataract. Saline version. Quadrant one.
Tell us, many people would like to know your parameters on.
Yeah.
I think they're shown on the right side.
Are the parameters visible on the screen?
Yeah.
Saline gun.
Right bottom, you can see the.
Not visible actually.
No, not visible.
No, actually it's there, but it's a little small. So that's
Okay.
why.
Can somebody please
Yeah.
focus on that? So you just hold at the edge so that the nucleus can be a little, the nucleus can be brought in. Saline, please.
So I think your aspiration rate is going up to about 30 to 40, and your vacuum is going up to 400.
400 around, yes, 400.
You can see now. And power is varying depending on the.
Yeah, I'm not actually full pedal at all. I'm just very lightly. Saline, please.
So vacuum is set at 400. The aspiration rate at 36, about 24 now. And power is varying from
30
to 40.
Quadrant high, full, saline open.
At the appearance, please, sir. Yeah. I put in the earpods for the mic. That's why my audio feedback is a little from the machine. Yeah. Okay. So you can see there's a lot of
Epinucleus.
yeah, still, it doesn't matter. So like this, so we can do a rehydro and then just loosen it up.
Sometimes what happens, the epinucleus is too hard for a. I mean, it's too.
Icky.
Yeah, too sticky for a. For a IA probe, it doesn't come
Yeah,
out that.
doesn't come out. Yeah, we might have to go in again and then do with the epinucleus mode. But this looks a little soft, so hopefully it should come out. Yeah,
So you go with the
Cortex,
no, I'm using the IA now. Screen thoda yaad usme kar. Acha, you're putting it on the screen. Okay, okay, okay.
cortex पे
Okay, okay.
Now you can maybe remove the settings because we possibly don't need it.
हाँ, IA का settings उतना नहीं. Yeah.
Or maybe decrease the machine settings. So I think when you have a thick epithelium like that, which is more on the thicker side, or cortical plate, which is more on the, it's coming out very well actually, even with time.
It's coming out very well. Yeah, now it's almost come out. Saline, yeah, a lot of cortex. Saline.
So you always use a bimanual for.
Always. Yeah, I'm very comfortable with the bimanual. I feel it gives very good access to all 360 degrees very well.
Yeah.
Okay, just change hands.
Also feel, but if you use a coaxial, then it gets a little faster because the port of the coaxial is, I think, possibly larger than.
side full saline, okay.
Yeah. But I'm very comfortable with the bimanual, so always use that.
Synergy 23.
Saline, please. Saline. So if you want to loosen up the cortex from the periphery when you're going really inside, then I go into the polish mode. And then you can come back to the cortex mode. So that you can be safe. So just loosening it up. So on the polish mode, there are a few strands here. So I'm just going in. Is it visible?
Yeah.
Yeah, it's very much visible. You can see how nicely you are removing the strand.
Be slightly breaking from these sides. Divers. So just loading the lens. I always load the lens myself. काकू 2 मिनटं लाईट दिसणार नाही ना.
तुमची लेन्स लोड होते हा.
So the platform, the cartridge is used is the same. So again, viscoelastic from behind as well as from the front. So the Synergy is a hybrid lens, but the advantages of both the EDOF as well as the acetylene, as well as the multifocal part. Gently loading it and turning the trailing haptic on top and pushing it gently. And then loading it onto the injector. Click sound and just check whether it's moving or not. So the advantage of the Synergy is even in low light conditions, it will give you very good vision. For near also, almost up to 33 centimeters. No, okay. Yeah. Plus continuous range of vision, right from distance, intermediate, as well as the near. Also has that violet light filter, so it gives good night vision also. Kaku सरळ बघा जरा. Right. Sometimes the haptic can stick to the optic, but can be easily removed.
Cortex height pulse
Just remove the wash of the viscoelastic. Saline. So in all these multifocal IOL patients, we usually do a complete workup, including an OCT of the macula, especially now this patient was a diabetic. Unfortunately, there is no diabetic retinopathy, and plus topography to see whether there are any changes or any problems. Especially if there is astigmatism also, then we have to confirm that it is a regular astigmatism. Also, we do a dry eye workup for these patients, do a TBAT and mammography analysis also, because especially in a diabetic where we are trying to put a multifocal IOL patient. So these are things which need to be checked really well. Selected.
He doesn't have any diabetic retinopathy, right?
No. But the patient has been counseled that you will need retinal monitoring once every 4 to 5 months.
And he has a good
at least.
glycemic control?
Yes, absolutely. That is why we were ready to put a multifocal IOL.
Yeah.
Otherwise, any patient with macular edema or any kind of diabetic retinopathy which is significant with a long-standing history, it's best avoided in my opinion. What is your opinion, ma'am, sir?
Yeah, absolutely, completely. Because if somebody is having a very good glycemic control, say 65 years of age, no diabetic retinopathy, I mean, one can go ahead with these lenses. But any doubt in glycemic control, then in such a case, it is avoided, and any even the mildest of diabetic retinopathy one should avoid. But this case does not have a diabetic retinopathy at all and has a very good glycemic control.
Correct.
Yeah. For me, I think I'm a little more conservative. If patient is diabetic, I avoid these lenses because you don't know when they'll develop diabetic retinopathy and when they would may have.
I would also go by the age of the patient. If somebody is say 50 years of age with diabetes, I will be a bit hesitant. Somebody 65, 70 years of age, no diabetic retinopathy, very good glycemic control, one may think of putting these lenses.
Correct. Also, if you look at now, for example, the next case, we are using an eye hands lens. So in such patients, here there is no.
Have we lost the connection? I think patient is.
I think here the advantage can be given to them.
Yeah. Okay, this patient is again. What's the age of the patient?
So here she is around 55.
55.
Yeah, and
there are systemic problems.
Sorry,
there are no systemic problems.
No systemic issues, and as you can see, it's a shorter eye. So the actual length is around 21.5.
Depth is good.
Sorry, ma'am.
AC depth is good, even though it
AC depth is good. Yes. And the IL power is 26 amperes. Actually, yeah. काकू काळजी करू नका सरळ बघत राहा दोन्ही डोळे उघडा So here we are planning the eye handsets. So it's basically a monofocal with the extended benefit of intelligent. दोन्ही डोळे आरामात उघडा सरळ बघा सरळ लाईट सरळ बघा हा बस 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 The advantages are it is a larger landing zone, intermediate vision, so it gives you a little more like a 0.5 diopters extra at 67 centimeters. So all those patients whom computer use or any kind of intermediate use is more. Plus here there is no issue of glare and halos or a loss of contrast. So the kind of platform is the same as the Technis one. So it gives excellent distance vision. Yeah, I hope it is well centered. So I'm using the.
It is absolutely well centered. You can see wonderful red glow.
This is the right 22. Line color. 3.2 and then 26 small vision 6 7. सरळ बघत राहा.
So which viscoelastic you use while doing the?
Oh, this is plain HVM.
Okay.
At this point of time, I use English plain.
So we saw that in the previous case you used Viscoat, I think, sodium hyaluronic.
Yes, that is just before the emulsification. When I use I use Viscoat like some.
So the microscope is really very nice, Anagha. We can see each and everything on the microscope.
Yeah.
The flap is beautifully being made.
But it really makes like similar and visibility is so good.
You can see the wave passing.
Yes, we could see the wave going.
Paper ready.
Here I would just initiate a discussion, Madam Dr. Namta. A lot of people these days are putting eye hair in conditions wherein they have some doubt regarding, say, somebody having, I mean, even in diabetics, people are mostly, they are a bit conservative, lens, but in diabetics, they very safely, they have shifted to your opinion on that?
No, I think I completely agree with you. If it is a diabetic patient, then I'll be more comfortable putting an eye hand the multifocal lens, And eye hands also, it's not a multifocal in true sense, it's a monofocal. So it's a monofocal lens, but it gives you additional benefits of intermediate and near vision. Maybe not so much near vision, but definitely intermediate.
And in such a case, if you are doing a both eye surgery, like one, so would you like to do some modification in the power of the other eye so that the patient gets a bit more of a near vision from one
and more of intermediate vision from the other? And this lens.
Yeah. So I guess it's a good find. It's a good addition to the armamentarium of an IO surgeon, wherein one has an option in conditions wherein one will be a bit hesitant in putting a multipurpose.
Yes.
Sure, right?
I think the settings now they have increased the size. We can see the settings.
Yeah.
Settings become.
We can see Anagha.
Yeah, we can see the settings very clearly now.
Okay, sorry.
Rate
Yeah.
varies from 22 to 36, and vacuum is around 400, which you generally use. Power is varying according to the power that you're actually using.
And what's the bottle height?
What is it? 85 to 90.
There is some sound which scan the audio. Just check what is
Yeah,
the sound
yeah.
coming down.
Sound which are because
Dr. Rajesh, can you hear me?
Yes, ma'am.
Okay, but we can't hear, I think, from the operation.
Yeah, yeah. Probably there was some noise in that, some disturbance in that, and maybe in order to remove that noise, the audio has gone. These
So
I've noticed that many people try to put some, fluid to loosen the cortical fibers.
yeah.
The aspiration is faster. Many times for small fibers, the tiny fibers that are attached to the capsule, they loosen up very easily if you can, put a jet of fluid. And that is useful in.
No, I have a feeling, and I could be wrong, and maybe you can share your experience on this. That
Yeah.
I have a feeling that when you do it with a coaxial,
Yeah.
those fiber kind of things are much less, and it's a faster method, of course. And the mouth of the coaxial which you have of the irrigation aspiration probe, that port is wider than the port of the bimanual irrigation aspiration. So it
Yeah.
tends to get a little slower.
Yeah, I agree with you. With the coaxial, it's a bit faster, and plus you can go with the maximum aspiration as well. The chamber also is very much stable every time.
Hello,
Then,
can you hear me?
Yeah, Naga, we've
yeah,
got
now
Yeah, in
we can.
between that, this thing
audio.
had gone on mute. The mic was on mute suddenly.
Yeah,
So
okay.
now they have adjusted it.
Yeah,
Sorry for
now the
that.
voice is also better.
Okay, okay. Maybe that sound, what is it? Kaku, Saral baga. Saline gun. Cortex. Yeah, saline gun. Yeah, you will start. Yeah. Correct. Elbow. Correct. Yeah, so we are going ahead with the eye. Lens ready to go?
It also is very much dependent on the type of bimanual that you're using,
Yeah.
quality of bimanual that you're using. Because when you use a coaxial, it is provided by the company, by the machine that you're using. It's the coaxial of the same machine. But bimanual varies in quality.
Lens.
And if you don't have a good quality bimanual, many times you get shallowing of chamber.
Chamber also, sometimes you have to extend the side port. Of course,
Yeah,
here Dr. Anaga's side port are equal to the size of the, both irrigation aspiration.
yeah.
Saline 2 cc. So there is a small.
Yeah, small.
Yes.
Yeah, so
This
that
is
hydro.
what we were discussing. that with a jet of fluid it can, yeah,
Jet of fluid
very nicely
easily
separate.
can remove. Yeah.
This
So,
is what we were discussing.
Dr. Rajesh, if you tell something else to Dr. Anagha to do, she'll do that also. We were just discussing this only, and then
Yeah, yeah. And fortunately, we had those
This
fibers
thing.
attached to the capsule so that you could demonstrate that.
Okay.
and the best part I like is that every single case you have shown the loading of the lens, because this
Yeah,
I think is really not shown that much, because
Right.
not very many surgeons do it themselves. So it's already loaded, but I think that is the best part of the entire surgery, that all
Thank
the
you.
lens which have been loaded, Anagha, so elegantly, and effortlessly.
yeah.
Thank you.
And
I wish I had a three-phase also, so that we could show that. But
no, I hope you don't have to share that. That's
yeah, yeah,
perfectly
yeah. I mean, I meant uh, a planned one.
yeah. But you so nicely and sweetly nudge it, into the
Nice.
nozzle. So this is the hands that we were all talking about,
I am, yes.
and I think the best part about it is that it is also priced really, very well for the function that it is going to give. It's not very. There's not too much of a difference between the monofocal lenses as well as the monofocal plus lens that is this.
Yeah. And regarding this injection of the IOL, many times I also use the shooter, and I use a 2.2 millimeter incision, and I implant wound assistant, dipping a little bit, so that doesn't cause any decimal detachment. Uh, Many times I have to tell the staff or my assistant to, you know, see to it that it is not very the movement of the plunger
Not
is not very rough, and it is smooth. That has to be ensured, and once that is ensured, then you don't have any problem. So that's what I've been doing it for so many years, but it has not happened. Any untoward has not happened, but you have to be a bit careful. You have to keep telling the staff to see to it that the movement of the plunger is not very, um, I would say, it should be smooth and not very turbulent. And in all the three cases, we could see that the injection of the IOL was very smooth. So
so, Anagha, again, that was so beautifully done. Watching your surgeries is, like hearing a song. It is, so effortlessly and
yeah, effortlessly and plus very methodically, actually. Everything done in a proper, uh, following a
Thank you so
proper.
much, ma'am. You have been very generous in your words. Thank you so much, and it's been a true pleasure for me. So, yeah, please see. Yeah, it's been a privilege for me, actually, absolutely.
no,
And I would like to congratulate you, Namrata ma'am, and Rajesh Sinha sir. You have been doing fantastic work in the last so many years for AIOS, and I'm really, we are all blessed to have leaders like you all, and especially in COVID times when we had such difficult times, AIOS has been standing behind each of us so strongly with such good scientific webinars and in all ways. So even things like this was totally unimaginable earlier. So really, thank you so much for being such a strong support and all the encouragement. I could otherwise never even imagine having, showing surgeries from our OT. So thank you so much for such beautiful ideas and standing behind our ophthalmic fraternity. Really hats off to you all. Thank you,
Thank
ma'am.
you, Dr. Naga, for being so kind. And your words are as smooth as your surgery. And really,
Thank you, ma'am. Thank you
Your
so
gives
much.
words
a
are
lot
like
of
music.
encouragement to
Yeah,
keep working hard.
yeah.
Thank you.
And you also keep shining like this, keep rocking like this, keep impressing
Thank you.
everybody. Beautiful set
Thank
of surgeries, and I think perhaps for the first time that now we have a women surgeon who's taken it all along, all by herself, on
you.
Yes.
her very young and very young shoulders, I must say. And you've taken along the whole Surginar, yourself. So I'm really
Thank you, ma'am.
completely enamored by that, impressed by it, and keep doing it like this.
Uh,
Thank
it
you
was
so
really fantastic. Very
Fantastic.
nice. Thank you.
Thank you, ma'am. Thank
Thank
you.
you. We would also like to thank Johnson and Johnson, who've been a
Yes.
support in doing this day after day. Earlier, I used to say month after month, and then I said week after week, and now I'm saying day after day because now they are, sometimes even doing twice a week. So thank you so much, Sami and Ashutosh, both. Of course, I would again like to, sometimes I do like to remember, and I would like to remember Mr. Jaswinder Singh here again, who was the person who actually got the Surgeonars on the forefront, who's no more with us. May he rest in peace. But thank you, everybody, and thank you once again, Johnson and Johnson, and our team back at home. I would say also, and would like to thank Dr. Rajesh Sinha, who's been a huge support always, standing shoulder to shoulder in every event that we do from the All India Ophthalmological Society headquarters.
Ma'am. Thank
So
you, ma'am. It's a privilege. It's a privilege, talking to two Dan.
Dr. Namrata ma'am is my role model.
thank you.
And so are you, Dr. Rajesh Sinha, sir. Thank you so much. Thank you to J&J from my side. Thank you.
Thank you.